So the rest of the time I'm going to spend going over the IDSA treatment guidelines. They were published in November 2005. I expect that we're going to be seeing something more revision-wise in the near future. And in order to go through a rather dry guideline, I'm going to try to illustrate some of the concepts with some cases. So the first case was someone that we saw, a 74-year-old lady with hypertension and hyperlipidemia, and she had a subacute onset of headache, cough, shortness of breath, and a pleuritic and non-pleuritic chest pain. She was fatigued and malaise, chills, night sweats. She didn't have any fever. And when she was initially evaluated, she had a slightly elevated white blood cell count at 10.2. She did have eosinophils, which was a tip-off. Sed rate was elevated, chest x-ray was performed, and the initial Coxy EIA was negative. And she just happened to have a baseline chest x-ray 1 month before she got symptoms. And in the right lung field there, you could see the new Coxy density. And a CT scan was performed subsequently, and you can see the nice nodule with some satellite lesions, very characteristic of Coxy infection. Well, she was diagnosed actually clinically with acute pulmonary coccidioidomycosis, and later the serology turned. Because she was already getting better by the time that was confirmed, we did not treat her. The nodule was followed, was stable, and didn't require any further treatment. So IDSA guidelines show if you have absent, mild, resolved symptoms, no antifungal therapy, but periodically reassess. And I think Dr. Empel stressed that nicely. If they're immunosuppressed, to say immunosuppressed sounds like it's a one-size-fits-all. Some I would consider treating, others I would say very definitely treat, like the kidney transplant, but for all, they need to be followed very closely. So case 2, a 48-year-old woman who's very healthy, came down from Minnesota, landscaping her Arizona home in December. 1 week later, comes down with fevers, chills, sweats, cough, shortness of breath, headache, etc. We know the drill. And this time, because she's sick, she was admitted to the hospital. And we happen to have an old x-ray on file 1 year earlier and can see that now she's got right greater than left, but definitely bilateral pulmonary infiltrate that rapidly progressed. And she so rapidly progressed that she went on to intubation, required mechanical ventilation. Of course, we don't say, hey, this is Coxy, and that's all we treat. She got very broad antibiotics. Her sputum culture did grow coccidioides as well as a conversion of her serology. She was given ambisome initially up front and was later changed over to fluconazole and did very, very well, other than the fact that she may never be back to her winter home again. So where we said in mild to absent resolved, really kind of nothing, not much going on, no treat. In moderate or severe infection, you definitely want to be administering something. If you have a rapidly progressive or severe case, then you want to be administering amphotericin. And if something's slightly less than that, and you're comfortable with fluconazole orally, then that is what I would consider, the drug of choice. Itraconazole is also perfectly acceptable, though I would mention to check levels.